Hello, everyone. Thank you for joining us this evening for From Perimenopause to Postmenopause, Evidence-Based Care and Counseling Strategies. My name is Angine Balint. I am the Professional Development Coordinator here at the OPA. I'm going to do a really quick introduction this evening, and then I'm going to let our speaker for the evening, Teresa Isabel Diaz, take it away. Of course, you know that this is tonight's topic. We actually did a webinar last week that is on a related topic on birth control. If you missed that, there is going to be the recording on our YouTube along with the recording for this webinar. And this webinar was developed by Teresa and the OPA and is supported through an education grant from Searchlight Pharma. So we thank them for their support.
Looks good. Hello, everyone. Thank you for being here to talk about the menopause transition, and I hope you will have a great time. Do pay attention today because if you do want the slides, I believe they will be distributed to the registrants sometime next week or whenever they are ready. So you don't have to worry about taking screenshots or pictures or anything else. My name is Teresa Isabel Diaz, and I have collaborated with and have received speakers' fee from these companies. And I will receive a speaker's fee for this current program from OPA. And this program has received financial support from Searchlight Pharma in the form of an educational grant. And by the end of this presentation, you should be able to describe the stages of menopause and recognize physical, cognitive, emotional, and sexual symptoms that can affect a woman's health and quality of life, identify and recommend evidence-based treatment options, including hormonal and non-hormonal therapies, and deliver safe, patient-centered menopause management. And you should be able to play an essential role in informing, supporting, and empowering women during the menopause transition to take charge of their health and well-being. Menopause is one point in a continuum of life stages. And as one of the important hormonal shifts in life, it is essentially the reverse of puberty. Menopause is caused by the loss of ovarian follicular function and a decline in circulating levels of sexual hormones such as estrogen and progesterone. Everyone born with ovaries will experience menopause if they live long enough. It is confirmed when a person hasn't had a period for 12 consecutive months. It usually happens between 45 and 55 years of age, and in North America, the average age is around 52. Early menopause happens between the ages of 40 and 44. The menopause transition can be gradual, usually beginning with changes in the menstrual cycle. And perimenopause refers to the time period from when these signs are first observed until 1 year after the final menstrual period. During perimenopause, estrogen and progesterone levels fluctuate, sometimes dramatically, leading to many symptoms. Peri can last 3 to 10 years and start in a person's late 30s or even early 40s. And about 1% of women may experience premature menopause, that's before age 40. Premature menopause can be spontaneous or can be induced by surgery, like removal of both ovaries, by medical treatments such as chemotherapy or radiation to treat certain cancers, or by ovarian suppression therapy used to prevent breast cancer from recurring. Postmenopause are the years after menopause is confirmed and lasts for the rest of the person's life. Estrogen is the predominant female sexual hormone, and there are estrogen receptors in nearly every cell throughout the body. It plays a crucial role not only in menstrual cycle, but also in various other biological processes. It influences cardiovascular function, cognitive health, and mood regulation, often impacting women's overall well-being and quality of life during menopause. Every woman experiences her unique menopause. Symptom severity varies by race, ethnicity, genetics, and factors like socioeconomic status, educational attainment, stress from systemic racism, and lifestyle choices such as diet and smoking. About 20% of women have no bothersome symptoms, and the majority report moderate to severe symptoms. Younger women with induced menopause often experience more intense symptoms and outcomes. Also, women with POI or polycystic ovarian insufficiency and premature or early menopause may be at increased risk for fractures, CVD, heart failure, diabetes, persistent vasomotor symptoms, loss of fertility, bone loss, genitourinary symptoms, sexual dysfunction, cognitive and mood changes, increased risk of dementia, open angle glaucoma, depression, poor quality of life, and overall mortality. Irregular bleeding is often the first sign of perimenopause, with menstrual cycles becoming erratic before stopping altogether. Vasomotor symptoms are the most commonly reported symptoms, affecting about 1/3 of women with frequent or severe symptoms, and these can last 7 to 10 years or even longer. And they may impact cardiovascular, bone, and brain health. These symptoms significantly affect quality of life and are the leading reason women seek treatment during menopause, for which menopause hormone therapy is indicated as first line therapy. But menopause involves more than just hot flashes. Many women also experience breast tenderness, insomnia, fatigue, bloating, and even new food sensitivities, headaches, joint pain, itchy skin, and changes in hair and body shape, often with weight gain around the midsection. Cognitive shifts like memory lapses and difficulty concentrating are common but often overlooked, and mood changes also frequently occur during this transition. These symptoms can significantly affect daily life and are important to recognize and to address. An older term, vulvovaginal atrophy, which you may remember, was replaced a few years ago with the new term genitourinary syndrome of menopause, since VVA did not encompass the full spectrum of symptoms. GSM describes a constellation of physical changes and symptoms resulting from a decrease in estrogen and other sex steroids as seen in menopause. And VVA is part of GSM. The vulva and vaginal lining become thin, dry, less elastic. The vaginal secretions diminish, leading to a loss of natural lubrication. And this can lead to pain with intercourse and to sexual dysfunction. The urinary symptoms of GSM include dysuria, urgency, frequency, and recurrent UTIs, which can cause sepsis and even death. It is important to realize that most GSM symptoms are not a normal part of aging and are not inevitable. They should be addressed and treated. In postmenopause, some of these symptoms improve. However, GSM worsens with time since menopause if left untreated. There's a knowledge gap when it comes to menopause. In 2022, over 10 million Canadian women aged 40 and above faced menopause with little support, despite it being universal, leading to avoidable suffering and reduced quality of life. Another report by the Menopause Foundation of Canada in 2023 focused on menopause in the workplace, and it revealed that 1 in 10 women may leave the workforce due to unmanaged menopause-related symptoms. And it was estimated that 540,000 workdays are lost annually due to unmanaged menopause symptoms. and that the overall cost to the economy is $3.5 billion. This slide depicts findings from a US study which looked at untreated VMS to understand overall costs to the system. It shows that untreated VMS are associated with direct and indirect costs, such as higher frequency of outpatient visits, increases in healthcare utilization, more days off work, and reduced productivity. Helping patients better manage their menopause-related symptoms can result not only in better quality of life for them, but could have ripple effects on the healthcare system, workplaces, and the economy. Let's then talk about treatment options. Here's the first poll question. In your experience, what's the greatest barrier to discussing menopause hormone therapy with patients? And please check all that apply to your practice. All right, so we have some answers. Lack of time, yeah, check. Limited training knowledge, yes, we must close the education gap for pharmacists and for women. Patients' fears or misconceptions, pharmacists' personal fears and concerns about liability are at the very bottom. Thank you very much for your answers. So, menopause hormone therapy is the most effective treatment for vasomotor symptoms and GSM, but its use is still very limited and even feared. And that's because of the results of the Women's Health Initiative trial that were announced in 2002. Yes, I was working, and one of my patients came up 3 days later in a rage because she had thrown her conjugated estrogen tablets down the toilet. So I remember these days very well. Many of you probably are too young to remember that. But I'll remind you, the WHI launched in 1991. It was a long-term national study focused on preventing heart disease, breast and colorectal cancer, and osteoporosis in postmenopausal women, when these are the leading causes of death and disability in older women. The trial did not aim to assess estrogen's effect on menopause symptoms like VMS, and in fact, few participants were under 60 years of age, fewer were less than 10 years postmenopause, or experiencing bothersome VMS. The WHI hormone trial had 3 arms: the estrogen plus progestin for women with a uterus, estrogen alone for those without, and a placebo group. It used only one administration oral, and only one formulation, 0.625 of CEE and 2.5 of MPA. And the estrogen plus progestin arm was stopped early in 2002 due to increased risk of breast cancer, heart disease, stroke, and blood clots. The estrogen alone arm ended in 2004 due to increased stroke risk and no overall benefit. A key limitation in interpreting WHI results was the emphasis on relative rather than absolute risks, and this may have skewed public and medical perception of hormone therapy safety. When the results were announced, and the media said things like, in a WHI trial, HT increased the risk of breast cancer by 26%. Many people interpret that to mean that when 100 women took HT in a trial, 26 of them developed breast cancer. But that's not what it means. When they say that the risk increased by 26%, it means that the risk for women to develop breast cancer, which is small, was increased by 26% when women took HT, hormone therapy, during the WHI trial. In terms of absolute risk, a 26% increase in the risk of breast cancer meant that an additional 8 women who were taking HT developed breast cancer compared to the women in the placebo arm. Regarding CVD risk in a WHI trial, relative 29% risk increase translated in 7 more women who were taking HT had a heart attack compared to those in the placebo arm. Just as we see with the use of combined oral contraceptives, risk of stroke and VTE increase with hormone use, and there was no difference in total mortality of all causes between the hormone arms and the placebo arm. If we look at the risks for the women aged 50 to 59, the age when most use MHT for symptom relief, in the women taking estrogen only in the WHI trial, the risk of CVD, stroke, breast cancer, colorectal cancer, and all-cause mortality, plus fracture and diabetes mellitus, decreased compared to those who are not on hormone therapy. Since the WHI trial, newer studies have introduced the concept of a window of opportunity where MHT initiated from menopause up to around age 60 or up to 10 years after the last menstrual period does not have harmful effects, but in fact, it will prevent comorbidities associated with menopause. Many of the reasons that most women and healthcare providers consider in making the decision to use or to not use MHT are still frequently wrong, incorrectly applied, or based in fear and or on outdated information. In the years since the WHI reports became public, we have learned much about the characteristics of women who are likely to benefit from MHT, and I highly recommend you read this hormone therapy position statement, and it's available free online. And as we've seen, menopause is a unique experience, therefore treatment should also be individualized because there's not a one-size-fits-all. Contraindications for systemic MHT include unexplained vaginal bleeding, severe liver disease, prior estrogen-sensitive cancers, CHD, stroke, MI, or VTE, or thromboembolic disease. Please do remember that migraine, smoking, and controlled hypertension are not contraindications. The benefits of HT include decreased VMS, vaginal dryness and tissue atrophy, and sleep problems. It may also decrease aches and pains. It prevents and treats osteoporosis. Although MHT reduces the risk of diagnosis of new onset type 2 diabetes, it is not government approved for this indication. May also lower the risk of CVD when initiated in younger women. And it may even have cognitive benefits when initiated immediately after removal of ovaries. But hormone therapy in the early natural postmenopause period has neutral effects on cognitive function. And MHT may also improve quality of life. So as you notice, MHT is not approved for disease prevention, but it's approved for several symptoms like VMS and GSM and even osteoporosis. The risks differ depending on type, dose, duration of use, route of administration, when it's initiated, and whether we take a progestogen with it. It may cause increased risk of VTE, stroke, and gallbladder problems, increased risk of breast cancer, with a treatment longer than 5 years in women with a uterus who also have to take a progestin. And these were the results we saw in the WHI trial. And when initiated in older women, the risk of CHD and of dementia may increase. Increased risk of endometrial hyperplasia in women with uterus not using concomitant uterine protection is also increased. The risk is also increased. As for ADRs, it is important to reassure women that breakthrough bleeding is normal for up to 6 months after starting therapy, and most have amenorrhea within 12 months. And it is just as important to advise women to see their doctor if they experience any vaginal bleeding after that. Those who cannot tolerate oral progestogens due to adverse effects, especially on mood, can take a TSEC, which is a tissue selective estrogen complex that pairs the selective estrogen receptor modulator bazodoxifene for endometrial protection with the conjugated estrogens. Or these women can also use progesterone capsules inserted vaginally instead of taken orally, or they can use a levonorgestrel IUD, and both these are off-label use. Following the WHI trial, hormone therapy options expanded, and here is a list of systemic estrogen and combination products available in Canada. Estrogen-only products include conjugated estrogens, and estradiol is available in several formulations. Combination products include tablets and patches of estradiol combined with netta and combined with progesterone, both in oral and transdermal formulations. And as I said, there's also a TSEC, a conjugated estrogen per SERM. When considering a progestogen, there are oral formulations of micronized progesterone, MPA, and netta. And a levonorgestrel intrauterine system is useful if oral progestogens are not tolerated. And this may also improve VMS symptoms, and it also provides contraception. Speaking of contraception, fertility of a woman during the perimenopause is lower, but at the same time, there are rates of unintended pregnancies among these women. Therefore, it is essential to counsel women in perimenopause on the importance of birth control until 1 or even 2 years after the last menstrual period if they want to avoid pregnancy. Many could benefit from the use of modern contraceptives, mainly hormonal, for contraception and also for menstrual cycle control, since abnormal uterine bleeding is common in perimenopause, for also bone protection, as well as reduction of VMS and menstrual migraines. And there are several options. There are cyclical or long-acting progestogens, and there's a new combined oral contraceptive that contains the progestin drospirenone combined with estetrol. Estetrol is a naturally occurring estrogen produced by the human fetal liver. But in this product, estetrol is synthesized from a plant source. It acts as an estrogen agonist on the vagina, the uterus, and the endometrium, the bones and the brain, and as an antagonist in breast tissues, which is a very good thing. With multiple estrogen delivery options, helping patients choose wisely for them is key. Oral therapy is familiar, it's easy, cost-effective, and improves lipid profiles. It's also the most studied route. However, it may raise risk of thrombosis and stroke. It increases triglycerides, CRP, gallstones, and pancreatitis. And it can lower libido by increasing SHBG, that complexes estrogen. Transdermal estrogen avoids hepatic first-pass metabolism, reducing impact on the triglycerides and CRP. It may lower thrombosis risk. It may cause fewer gastrointestinal side effects, and it may preserve libido. The downsides may include possible skin sensitivity. The patches can be visible, and it's higher cost than oral options. TD therapy is preferred for those women with VTE risk or those with poor oral absorption, obesity, smoking, hypertension, migraines, or low libido. This is brand new. The Canadian Menopause Society has just released a conversion table for menopause hormone therapy, including the recommended doses of progestogens. And this table available online may assist you, especially when switching between various estrogen and progestogen formulations. As we know, with all the back orders and shortages, we have to give the doctors options. So this is a great tool to use in your practice. It is also important that pharmacists help close the menopause education and support gap and convey to our patients that menopause hormone therapy is the most effective treatment for VSM and GSM. It could be initiated for bone protection. It should be initiated in premature ovarian insufficiency. And many women experiencing premature or early menopause who have no contraindications for MHT can be considered to take hormone therapy until they reach the average age of menopause. For these women, treatment for a longer duration and perhaps at higher doses is often necessary, not only to control symptoms, but also to lower the risk of diseases later in life. And it may also improve mood, joint pain, sleep, sexuality, and quality of life. Hormone therapy risks vary by type, dose, duration, and when it started, and if a progestogen is used. For healthy women under 60 years of age or within 10 years of menopause or within 10 years of the last menstrual period, for these women, the benefits often outweigh the risks. Monitoring individualized treatment is crucial, and for some, longer duration may be required. Another poll. Which of the following statements aligns with current guidelines regarding the duration of MHT for VMS? All right. MHT duration should be based on individual system relief and risk profile. That got most votes, and the others just got a few little votes. Okay, so the correct answer is C. You are all right. Guidelines recommend decisions on continuing MHT should involve a shared decision-making process, a shared decision-making process between the patient and their clinician, considering factors such as symptom relief, quality of life, and individual risk factors for conditions like coronary heart disease, stroke, and venous thromboembolism. And some women may just say they want to continue. So it's more risky to start after age 60, but it does not have to be stopped when a woman turns 60. Women who avoid or cannot take MHT have non-hormonal options for vasomotor symptoms. Though supporting evidence is limited and long-term data is sparse. This 2023 position statement provides helpful guidance. It's freely available online and well worth reviewing. Pharmacologic options that have demonstrated some benefit for hot flashes include SSRIs and SNRIs. Gabapentin is especially effective for night sweats, which are hot flashes that happen during sleep. And the doses used for the treatment of EMS are usually much lower than those used for the treatment of depression. And these medications show results are effective much quicker than when taken for depression as well. Clonidine is no longer recommended due to a high incidence of adverse effects, and pregabalin isn't recommended because of controlled substance prescribing restrictions. Fezolinetant is a new class of medication for VMS available in Canada now. It is a non-hormonal selective neurokinin 3 receptor antagonist. It modulates neuronal activity in the thermoregulatory center in the hypothalamus, where hot flashes seem to originate. CBT, or cognitive behavioral therapy, has shown promising results in managing VMS. And now we go into the GSM because we must talk about this. It affects 75% of postmenopausal women, yet only about 25% seek care. Despite its high prevalence, GSM remains underdiagnosed and undertreated. And this condition can significantly impair health, sexual function, and overall quality of life. Yet many, many women suffer in silence, often due to lack of awareness about available treatments, stigma, or even fear of therapies. These numbers reveal a major care gap that needs urgent attention. To help close this gap, I recommend you read this position statement and familiarize yourselves with a full range of treatment options and empower more informed and compassionate care. GSM can affect any woman. It's just not a problem for those who are sexually active. And younger women undergoing chemotherapy, pelvic radiation, ovarian surgery, or those taking aromatase inhibitors face higher risk due to the very rapid estrogen loss. The primary goal of treatment is symptom relief, and a stepwise approach using non-hormonal and hormonal therapies is often effective. All listed therapies here on this table may be recommended to patients, including those with hormone receptor positive cancers, who are those who cannot use hormone therapy. Pharmacists should educate patients about GSM, educate patients about first-line therapy, which includes lubricants, and also help patients distinguish between lubricants and moisturizers. Lubricants are used during sex to reduce friction and improve pleasure, and moisturizers are used regularly to maintain and retain tissue moisture. Silicone and oil-based lubricants seem to be less irritating than water-based lubricants, and hyaluronic acid-based moisturizers are often more effective than water-based ones, and they are especially good for women survivors of breast cancer, as seen in one small study. Vibrators may stimulate natural lubrication, while pelvic floor therapy and dilator use should be guided by a pelvic floor therapist. Intravaginal laser therapy can improve vaginal health and reduce dyspareunia in breast cancer survivors. And if symptoms persist, prescription hormonal and non-hormonal medications may be considered when appropriate. Low-dose vaginal estrogen is available in creams, ovules, and as a ring. It is effective and generally safe for GSM with minimal systemic absorption. It is preferred over systemic estrogen for localized symptoms if there's no other symptoms such as VMS, for example. And a concomitant use of a progestogen is not needed, though long-term data are limited. Health Canada approved non-estrogen options include vaginal DHEA, prescription only, not the stuff on OTC, and also ospamifene, it's an oral SERM. Systemic hormone therapy may help GSM, but if women are using very low doses of systemic estrogen therapy for VMS, for example, it may not be very effective for GSM, so local treatment is often still required, and it is okay to use both. Symptom relief may begin within weeks, and long-term use is recommended if there are no contraindications, because symptoms often return after stopping treatment. For women with breast cancer, any vaginal estrogen should be prescribed in consultation with their oncologist. I also recommend you read this consensus recommendation for the management of GSM in women with or are high risk for breast cancer. Yes, it's available online for free. When you dispense a low dose vaginal product, the patient must be prepared for the boxed warnings and educated about the differences between the risk of using low dose vaginal estrogen and the risk of using systemic estrogen, or else they may not initiate the prescribed treatment. And that is because the package insert for vaginal products includes the same boxed warnings regarding risks that accompanies systemic hormone therapy products. But these risks are highly unlikely given minimal systemic absorption and reassuring findings from clinical trials and observational studies. The most important advice pharmacists can give a postmenopausal woman using vaginal estrogen therapy is to report any vaginal bleeding or spotting right away because of risk of endometrial hyperplasia. Last poll. Which treatment option for GSM are you most comfortable discussing with patients? Check all that apply, and I hope it's many. Okay, non-hormonal lubricant and moisturizers and local vaginal estrogen are up there. That's good to know. It's stepwise approach. We may start with a non-hormonal lubricants and moisturizers, and if that stops working or doesn't work at all, we can move up the ladder into local vaginal estrogen. Great. I was hoping no one would say E, because I hope you realize that GSM is treatable and how important it is to discuss evidence-based available therapies with your patients. Moving on to your role in informing, supporting, and empowering women during the menopause transition. As one of the most accessible and trusted healthcare professionals, you and we are uniquely positioned to make a powerful difference in the lives of women navigating the menopause transition and beyond. Your clinical expertise, combined with your regular contact with patients, puts you at the forefront of care, educating, counseling, and supporting women when they need the most. And how can you provide menopause support? Let's see a few examples. Initiating menopause conversations with women aged 45 to 55. Initiating conversations with breast cancer survivors, with those post-hysterectomy, and with patients on prophylactics for breast cancer, such as aromatase inhibitors, is essential. The MQS tool can support this dialogue. And once individuals needing support are identified, do explore symptoms and treatment options with your patients. Educate them about non-hormonal, hormonal therapies, outlining the benefits, the risks, and addressing misconceptions to support informed decisions. And monitor treatment effectiveness and tolerability and adjust the therapy as needed. Counsel patients on the importance of staying consistent with prescribed therapies to improve symptoms, to improve quality of life, and reduce long-term risks. Schedule follow-ups to monitor progress, to address barriers, and to offer encouragement. Health status and medications change, so reassess hormone therapy periodically based on symptoms, overall health, the benefits, the risks, the goals, and the preferences. If or when needed, help guide decisions about tapering or discontinuing therapy. Some women decide to go on MHT to relieve symptoms for a few years, and then they want to stop therapy and reassess if the symptoms persist. It's okay to stop MHT for 3 months, and if needed, it can be restarted. And share trusted resources like the SOGC website menopauseonu.ca for guidance on symptoms, therapies, sexual health, and more. This describes the experience of many women in midlife that may show up in your practice. Often they don't realize that what they are experiencing, VMS, night awakenings, memory lapses, fatigue, anger, irritability, is linked to the hormonal changes of menopause. Many, they may feel unwell and confused and even fearful, believing something is seriously wrong. And that's why education is so critical. Menopause related symptoms can be disruptive, interfering with sleep, daily functioning, emotional well being, and work performance. Women should not have to simply endure these symptoms or wait 5 to 10 years for them to resolve on their own. Effective treatments exist, and women need and deserve to know about them. What can we tell these women to help them feel informed, empowered, and supported? Validate their symptoms. Women deserve to have their experiences acknowledged and taken seriously. They are not going crazy. It's essential to rule out underlying medical conditions that may present with similar symptoms. For example, anemia, hypothyroidism, vitamin D deficiency, and others. You can encourage a healthy lifestyle, but reassure them that evidence-based treatments are available and are effective. In fact, if a woman is otherwise healthy and has no contraindications, MHT remains the gold standard for treating VMS. And since breast cancer is the most feared risk of MHT and the reason why so many women don't take it, ask this patient if that is a concern for her. And take the opportunity to reassure her that the risk of breast cancer associated with MHT is very low, particularly in the first 5 years of use. And it's comparable to other risk factors she may not know about, as drinking 2 alcoholic beverages a day. MHT may offer additional benefits. Evidence suggests that when initiated within the window of opportunity, that time women under 60 or within 10 years of menopause, it may help reduce the risk of heart disease and fractures. Offer her assessment tools to identify risks for heart disease, breast cancer, and osteoporosis. There's amazing resources online, and this is the chance to empower her with facts, not fear, and help her make an informed decision that supports both a symptom relief and long-term health. If she is a breast cancer survivor, discuss non-hormonal therapies for VMS. And you should also take the opportunity to discuss GSM. It's rarely brought up at the doctor's office. The doctors rarely ask women about it. The women don't share, and it's a condition affecting so many women who suffer in silence. And consider becoming a Menopause Society certified practitioner yourself. This credential, formerly NCMP, reflects advanced expertise in midlife women's health. It's open to licensed healthcare professionals, and the MSCP requires passing a rigorous exam, is valid for 3 years with renewal via re-examination, or easier, via continuing education. I earned my certification in 2013, and it deepened my knowledge and enhanced my ability to support women through menopause. If you are committed to delivering informed, compassionate care, this certification is a meaningful way to elevate your clinical skills and impact your business. Key points: VSM, GSM, and other menopause-related symptoms are common. They impact quality of life, and they often go undertreated. MHT is first-line therapy with the benefits outweighing the risks for healthy women under 60 years of age or within 10 years of the last menstrual period. Non-hormonal options exist for those with contraindications to MHT, and pharmacists can play a key role in supporting women through education, personalized care, and ongoing monitoring. Here are the references and resources I used and recommend you review. And as I said, you will receive a PDF of these slides. So please go through these references afterwards and check them out. They are really, really good. And thank you very much for your attention. And I believe we have a few minutes for questions.
Yes. All right. First of all, I just want to say thank you so much, Teresa. That was a great presentation. There's obviously a lot of really great, important clinical information in there, but I just want to highlight your overall philosophy to women's health, how refreshing that is, especially your focus on education and like being upfront and asking about women's experiences. I think that's something that is a struggle across healthcare in general. So it's really great to hear someone speak so openly and so passionately about it. So yeah, so thank you so much. We have one question here. Oh, we have a couple. There's more popping up, so we have three.
Good. Keep them coming.
We have 10
have 10
minutes, so we're
minutes
good
at
for time,
least.
don't worry.
Yes.
Is vaginal hormone therapy considered safe in one who has been treated lumpectomy and radiation for breast cancer, DCIS/stage 0, where pathology confirmed the tissue was hormone receptor positive?
So I did say that on my slide. It depends on a lot of things. Depends how bad the GSM is. Depends how much the woman wants to put up with it or treat it. Depends how a breast cancer risk going forward is. And the decision should be made by the woman, her oncologist who knows about her cancer better than anyone else, and the prescribing doctor if it is a different doctor. And you can also help a woman on this making this decision by educating her about all options of treatment. Some women have such miserable sexual dysfunction, um, and you will see if you read that consensus paper about treatment of GSM in women with cancer or high risk for cancer. It separates the different kinds of cancer and the different kinds of risk and the different kinds of life expectation, and gives you guidelines for which treatment are most beneficial for all those case scenarios. So that's a great question. I don't have an answer for you, but if you read that paper and you talk to the woman about all these options, ultimately she, with the oncologist care, should be able to make an informed decision that is helpful for her.
Great.
Great question.
For how long can one be on MHT if started within 10 years of menopause?
So we assume this woman is healthy when she starts MHD and she's under the age of 60 or within 10 years of menopause. She's healthy. If for some reason she never develops any contraindications, if she does not have a heart attack, if she does not have any estrogen receptor cancers, and she's doing fine on hormone therapy and she wants to hold on to it for dear life, she can take it until the situation changes. If her health status change and she gets contraindications, it's good to know until that the risk increases. Because if she stops the therapy early, the risk of osteoporosis comes back right away. So if she's taking it for VMS, but also for prevention of osteoporosis, because she's at very high risk of osteoporosis, she will lose all that protection once she stops it. So there's no hard stoppage here. It depends on overall health, on the woman's preferences, on the risks, and ultimately on informed decision.
Someone asked, can TD patches be cut?
Ha! That's a Dirk question. Drug Information Resource Center all over again. I don't know how many times I gave this answer when I was working at OPA Dirk. Uh, Technically, no, because we don't have any data on how the patches work if they cut, which no manufacturer who makes patches ever cut one and told us it works, it doesn't work, it's safe, it's not safe, because they just don't do that. And also because there's so many doses these days. I know there's a lot of back orders and shortages, but there's a lot of doses for different patches. So I can't recommend you cut a patch. If you do it, you have to tell the patient that I have no data to tell me if this is safe and effective and how it's going to work for you. So, and if you need to change medication because oral therapy does not work well and you have to take a patch, that Canadian Menopause Society brand new equivalency PDF is very, very helpful in your practice. So just print it and put it in a pharmacy. It's really good. It's not perfect science because there's never been head-to-head trials to tell us 0.625 milligrams of conjugated estrogens and 2 milligrams of estradiol or a patch of 50 micrograms of estradiol give you this result. There's no head-to-head trials between oral and transdermal estrogens. So it's an approximation based on results.
The questions just keep rolling in, so we're just going to keep answering
We'll
them.
just keep answering it.
Is it reasonable to treat menopausal symptoms with progesterone only? Patient was previously on Mirena IUD, but is no longer needed, and MHT symptoms start after removal.
You can try. Some women, progesterone seems to be the first hormone that decreases in perimenopause. It's the calming hormone, and many women find that they have much difficulty sleeping because progesterone has gone down. If they have no contraindications to taking progesterone, and if they were on a Mirena with results, they may want to try progesterone for symptom relief. Yeah, it's possible.
What are your thoughts on Duaviv? I'm not sure.
Duaviv, yes, that's a
In a
tech.
healthy woman, is it safe?
There's just been interesting you asked that question. I know Duaviv, I think, was back order for a whole 2 years, and now it's back in town, which is a good thing because it's an option, especially good for those who don't tolerate progestogens. Having said that, there's new data on Duaviv that shows that the risk of breast cancer with Duaviv is lower than initially thought. So if the concern, like for many women, the concern is, I don't want to take MHT because it causes breast cancer. Duaviv seems to have very good data now on no significant increase in breast cancer because of that SERM, the basadoxaphene, seems to have very good protection for breast cancer and also for endometrial hyperplasia. So it seems to be a good option. That's recent data from last year, I believe, so it's good to know about that. You don't have to start a woman on, sorry, Angie, you know, you don't have to start someone on something else before you go to Duaviv. You can start the person on Duaviv right away. Conjugated estrogen, it's a low dose, so it may not work for all. It's a 0.3 instead of 0.625, but if it works, there's good data for safety if it works for vasomotor symptoms. And it's also in the middle of all this, I didn't say that on the slides, but I'll say it now. It's important that we ask women what their expectations are. And there's two lines of thought. Some like to start in a high dose and decrease until symptoms return. I think that sucks. I prefer to start low and increase until the symptoms are tolerable. We cannot promise women that they will be completely free of all menopause related symptoms. So it's good to ask, what are your expectations? What do you want from this therapy? They may say, I want to go back to sleep 8 hours a day so I can function next day. Some may say, I want to have pleasurable sex with my husband again, or I'm going to get divorced. It depends. It's so individualized, but it's important for us to ask them and then keep their expectations accordingly to the medication. It's not a one size fits all, and it's not a one, it's going to fix everything. You're going to be 30 again. No, you won't.
I see in long-term care some ladies on MHT. Pill burden? Question mark.
Uh, Again, they are long-term care. They probably haven't got a fracture yet. They stop the menopause therapy, they fall, they break, and they're dead in 1 year after fracture. The risk of fracture and death is humongous. If these women are healthy and they are doing well on hormone therapy, why stop? You have to find out if there's a good reason to stop. If there is no good reason, ask them if they want to stop and then give them the information. They should be the ones to tell you if they want to continue or not based on your explanation of the benefits and the risks.
If a patient had early menopause at age 42 and is now 49 with mild vasomotor symptoms, is there any benefit to starting MHT? Should it be recommended or only offered if the patient requests?
Well, does the patient know there's hormone therapy, there's therapy to treat a VMS? I would start by if you know this patient has vasomotor symptoms, you should ask and find out how much they impact her quality of life. If she can't sleep, if she's waking up at night, changing pajamas twice a night, she's a wreck next day because she can't sleep, that's a good option. There could be other reasons why she wants to get rid of her vasomotor symptoms. And it's very important to have younger women taking menopause therapy because we know that the younger you are when estrogen leaves your system, the higher the risk for those diseases, cardiovascular disease, diabetes, dementia, and osteoporosis. So if she was 42 and she's 49, she's only within 7 years of menopause and she's less than 60. So she's a perfect candidate for hormone therapy. So you should educate her about the benefits and the risks.
Okay, we are at time, but we have two more questions,
All
so I'm going
right,
to try to get
I'll
those answered.
stay. Whoever wants to listen, I'll stay.
Okay, how long to use birth control and difference in moisturizer versus lubricant?
Birth control is a good question. Sometimes women don't know if they are in menopause or not because they're taking a contraceptive, a pill, oral combined oral contraceptive. So therefore, they're having a forced period. So if they stop it and then they don't have a period for a year, they know they are in menopause because menopause is confirmed after 12 months of no periods. But they may get pregnant in the meantime, and we don't want that if they don't want that. So you can start, you can tell them that if they want, they can use the oral contraceptive until the average age of menopause in North America, that is 52, and then use some other form of birth control if they want to see if they are in postmenopause or not. So it's an option.
Okay, how does compounded topical therapy for menopause compare to commercially available products?
So there's no data, as much data in topical compounded therapy as there is in pharmaceutically commercially available therapy. So that's the main issue, is lack of studies that show you the effect, if safety, efficacy, and also how is this product you're compounding um, going to prevent osteoporosis, CVD, and dementia, for example, especially osteoporosis. Not that I know and that I've heard other people talk about, there are no studies done on these compounded recipes, um, no studies done to tell us what dose do we need to prevent osteoporosis. So we can't, it may work for vasomotor symptoms and it may not increase the risk um, breast cancer or whatever, but we don't know that either because there's no studies. So I I like science-based, evidence-based medicine. So I go with the products that I have data to show for benefits and risks.
There's still a couple more questions. There's
Go
three
on.
left, guys. After that, we're gonna cut it off. Thank you for all these questions, though. They are great. Um, how should we approach patients who are 45 plus and using hormonal IUDs?
um, Great question. Are they having are they having vasomotor symptoms? Um, are they feeling okay with it? Do they need to change? Um, you can't go by the change in periods. So irregular periods probably won't show up because they have been without periods for a long time due to these IUDs. But you can ask about the other symptoms that I put up. Are you getting hot flashes? Are you getting difficulty sleeping? Are you getting memory lapses? Are you getting irritable? Are you getting angry? Are you yelling at everyone? Are you all those things could be a sign that hormones are shifting and that the hormone in the IUD is not enough to take care of those symptoms. And then we go back to the same issue. Do we stop the IUD and use another contraceptive? And this woman then reassesses where she is in the menopause continuum. Is she in peri or postmenopause? So we have to talk about symptoms, we have to talk about contraception and what she wants.
That same person just commented. They said so they can still use MHT add-on.
Depends. That's very individualized. Um, at she was 45, you said?
45 plus.
Um, I wouldn't use MHT. I would use MHT, but I would just use estrogen probably because you already have the progestin from the IUD. So you don't need to add to have two progestogens from MHT. So MHT is estrogen plus progestogen for women with a uterus. If this person has a IUD and she's showing symptoms of menopause and wants to treat those, then just add a low dose of estrogen and see how things go. After you rule out all the contraindications and send it to physical and check for cardiovascular risk, osteoporosis, and any medical conditions, and do a lab work, CBC count, everything.
Thoughts on Veoza? Not sure if I'm saying that
Uh-huh.
right.
Don't have any. I don't have any. Hormonal tests, you go ahead and Jean, you say that.
The next question, is there any benefit to using progestin in women without a uterus?
Not really. Um, Not really. If they have symptoms, the evidence, the data from the WHI trial, especially on women without a uterus taking only estrogen, is very strong. It reduced the risk of a lot of deadly chronic conditions, cardiovascular disease, osteoporosis, diabetes, all that. So I would not give this woman a progestogen if she has symptoms. Give her some estrogen, go low and go slow, and see how she feels. But I would not go for progestogen because the main function of progestogen in MHD is protection of the endometrium. If she does not have an endometrium, she does not need the protection.
Okay. One last one. This was the person who was asking about IUDs and MHT. Hormone level tests are not required to start on MHT. Is that valid?
That is valid, but there's like everything in medicine, there's a few exceptions. So, for example, if a woman has had a hysterectomy, she's no longer bleeding, so we can't count 12 months of no periods to diagnose menopause. So that if she's experiencing symptoms, and she cannot relate irregular periods and lack of periods to to time menopause. For that reason, uh, it's valid to have blood tests, not saliva tests, but blood tests may be helpful for diagnosing menopause stage.
Okay. All right, great. Thank you guys
Thank
for
you.
joining us this evening. Thank you for all your wonderful questions. Again, thank you so much, Teresa, for your presentation. Do you have any final words for our learners this evening?
Close the gap of awareness, education, and support, and make women's life in midlife better.
Great, thank you so much. So this has been recorded along with last week's webinar. You can check it out on our YouTube, probably be up within the next week, maybe 2 weeks. You are also, anyone who attended this evening is going to get a copy of the slides, as Teresa mentioned. So watch out for those, a ton of great resources. A thank you to our sponsor, Searchlight. And yeah, everyone have a great evening and thank you for joining us.
Thank you.